everybody has a chance to access the program today. So thanks so much for your understanding. All right, let's go ahead and get started. My name is Ayako Miyashita Ochoa. I go by she, her pronouns. We're here today joined by a couple of great folks, leaders, community leaders, and state partners to talk about new guidelines for PrEP coverage in California. So I'm pleased to be able to stand on this platform. We are all part of the California HIV/AIDS Policy Research Center. We have 3 centers throughout the state. And our centers are focused on bringing relevant and timely evidence to bear on HIV/AIDS policymaking here in the state of California, in service to developing or informing the development of and maintaining efficient, cost-effective, and accessible programs and services to people both living with and at risk for HIV. So pleased to be joined by my colleagues here today. First, I have Ann Donnelly. Ann, if you can wave. There's a lot of folks on the call today, so if you don't see her, hopefully you'll see her when she starts her presentation. Ann Donnelly goes by she, her pronouns, Director of State Healthcare Policy at the San Francisco AIDS Foundation. Craig Pulsifer, he, him, wave Craig if you can, Associate Director of Government Affairs at EPLA Health. And last but certainly not least, Reina Hernandez goes by they, them pronouns, Associate Director, PrEP and HIV Navigation Services at San Francisco AIDS Foundation. So the presentation today, as we made note of it before, is about the U.S. Preventative Services Task Force Grade A recommendation for PrEP and Senate Bill 159 as it relates to prior authorization step therapy, and what are really the implications of recent changes in the regulations related to those. So as we get started, just a few housekeeping items. Please feel free to introduce yourself in chat, just so we know who you are and where you hail from and what interested you in our program today. Also for Q&A, my colleague Alex will be tracking those in the chat. So feel free to go ahead and put them into chat. What we'll do is we'll save some time at the end to get to the Q&A. Otherwise, we will look forward to connecting with you towards the end. We'd like for you to do an evaluation, so please do stay until the end. And with that, I will hand it over to my colleague, Ann Donnelly.
Thanks, Ayako. And I think we did want to tell people as well that there's a fact sheet and a brief that you will have access to. We may be sending it out. We can talk about at the end about what we're going to do with that. And I just wanted to take a minute to welcome Jessica Ryan from the California Department of Insurance and Amanda Levy from the Department of Managed Healthcare. And I really want to thank you both for your partnership and your leadership in ensuring that plans in California both know about these regulations and comply with them, and how much that has supported PrEP access in California. So thank you. We're really grateful for your partnership. And so we wanted to give you a little bit of background on this. And I know you're all familiar with PrEP. I know you all know that there are currently 3 medications used for PrEP, Descovy, Truvada, and a generic version of Truvada. And I'm sure you know as well that we're looking forward to an injectable PrEP in the near future. I think we expect to see approval in the beginning of next year. Is that correct, Craig? Okay. But the issue is that only 1/4 of people who could benefit from the use of PrEP are actually able to use it right now due to a number of barriers. So we are seeing great disparities in PrEP use, and it's lowest among Black and Latino, gay and bisexual men, women, young children, or young people, and transgender individuals. So it's of great concern, and that's part of the reason we want to ensure that everyone knows how to access PrEP in this environment. So next slide, please, Ayako. So there are 2 important set of guidelines and regulations that support PrEP access. And the first one is federal regulation. So as Ayako mentioned, the Affordable Care Act actually requires most private health plans to cover preventative services that are recommended by the U.S. Preventative Services Task Force, or the USPSTF, and they're required to be covered with no cost sharing. And so in June of 2019, PrEP did get a grade A, as Ayako mentioned, and that means it does need to be covered with no cost sharing in most plans. But the only exception to that is grandfathered plans, and that covers those plans cover about 1 million Californians, and that number is decreasing the further that we get from the initiation of the Affordable Care Act. The second regulation or set of regulations is state, and that it was authorized by SB or Senate Bill 159, which was also signed into law in 2019. And that prohibits most private health plans from requiring prior authorization or step therapy for PrEP and PEP. And in real life, what that means is that all California state regulated plans have to include Descovy on their formulary because there's no therapeutic equivalent. And they do not have to necessarily have brand name Truvada on their formulary, but they do need to provide access to generic Truvada. So the healthcare regulatory environment is very complex. And so I'm going to turn it over to Craig to walk us through the private market and how these federal and state regulations apply to plans in the private market.
Yeah, thanks, Anne. And yeah, so like Anne said, this USPSTF grade A rating requires private health plans to cover PrEP without cost sharing. So before we get into kind of what the specific regulations look like in California, we want to give folks a sense of what health plan enrollment looks like and who regulates these different types of plans. And so this is data from 2019. I'm not sure if you can see my cursor, but you see here individual, small group, and large group. These are private health plans that are regulated by the state. So when we talk about state regulated private health plans, this is it right here. It's about 14.5 million Californians. Over here in green, these are ASO. That stands for Administrative Services Only, but what these are employer plans that are self-insured, and these plans are actually not regulated by the state, but they're regulated at the federal level. And so what we're gonna do today is we're gonna break down kind of what the requirements are for private health plans, depending whether they are regulated by the state or whether they are regulated by the federal government. So you'll see that the large majority of private health plans are state regulated. And we do have the strongest protections in California for state regulated plans, thanks to regulations from the Department of Managed Healthcare and the California Department of Insurance. So we'll start by talking about what the requirements are for these private state regulated plans. And then we'll talk about this subset of plans, the self-insured employer plans, and what the requirements are for those. You'll see here, of course, the public health programs. And so Medicare that provides health coverage for older adults and people with disabilities, and Medi-Cal that provides coverage for low-income Californians. And so we will talk about those later in the presentation as well. So like I said, we'll start here with the state regulated private health plans and what the requirements are. So these health plans, the large majority of the state regulated plans are regulated by the Department of Managed Healthcare, about 13.4 million lives. And then some of those are regulated by the Department of Insurance, about 1.1 million lives. And so we have received very strong guidance from both DMHC and CDI that essentially say these health plans have to cover all FDA approved medications for PrEP without cost sharing. And then they also have to cover all of the clinical services without cost sharing. So this would include provider visits, HIV and STI testing, kidney function testing, testing for hepatitis B and C, Hep B and Hep B vaccination. So all of these services need to be covered before any deductible and without any copayment or other cost sharing. So again, if folks have questions, please put those into the chat as we're going through this, and we'll make sure to get all of those answered at the end. In terms of Senate Bill 159, so again, we're talking about state regulated health plans. This is the large majority of private health plans in California. Under Senate Bill 159, these plans generally cannot require prior authorization or step therapy for PrEP and PEP. I imagine most folks are familiar with prior authorization. Prior authorization usually means that you have to get special approval from your health plan before you can be prescribed a medication. And in step therapy, sometimes you have to try a different medication before you can use another, usually more costly medication. And so under Senate Bill 159, most private health plans cannot require prior authorization or step therapy for PrEP and PEP. The only exception is if there is a therapeutically equivalent version of a medication. So in the case of PrEP, we do have a generic version of Truvada. So what that means is that health plans can require prior authorization or step therapy for Truvada because there is a generic version. However, Descovy currently does not have a generic or therapeutically equivalent version. So I think this is probably where we have seen the most challenges with prior authorization is around plans requiring prior authorization for Descovy. So a key point here is that most health plans in California can no longer require prior authorization for Descovy. So next, we're going to move into the next set of health plans. And so this was that column in green, the self-insured employer plans. And I'll talk a little bit about how to find out if your plan is self-insured. But these plans, again, are not regulated by the Department of Managed Healthcare or the Department of Insurance. They are regulated at the federal level by the Department of Labor. So if you are enrolled in an employer plan, there's a couple ways that you could find out if your plan is self-insured. You could look at your health plan documents, like the evidence of coverage, and that will say kind of who regulates your plan and who you can go to with complaints. But another really easy way is if you're in an employer plan, you can just talk to your employee benefits administrator or your HR departments, and they should also be able to provide you with that information, whether your employer health plan is self-insured. So I'm going to talk about what the specific requirements are for these plans. The good news is, in terms of cost sharing, the regulations are very similar to state regulated plans. So we received very strong federal guidance that these plans are also required to cover PrEP medication and all of the clinical services without cost sharing. So essentially what this means is all private health plans in California are required to cover the medication and all of the clinical services without cost sharing. An important difference is when it comes to prior authorization. So self-insured employer plans, because they are regulated at the federal level, they can require prior authorization or step therapy for PrEP. But the federal guidance does say that if a plan requires prior authorization, for example, the process needs to be expedient and allow people to start PrEP on the same day as their visit or negative HIV test. And so this cannot be an overly burdensome prior authorization process that makes it difficult for folks to access the PrEP medication that they need. And when it comes to cost sharing, if a plan does have prior authorization for Descovy, for example, if that prior authorization request is approved, Descovy still needs to be covered without cost sharing. So very, very happy. This is good news for California across the board, I think, regardless of what type of health plan you're in, but it's just very important to understand some of these nuances, especially as you're working with clients and helping them navigate some of these issues around cost sharing and prior authorization requirements. So I'm going to pass it back to Anne just to go over some of the requirements in Medi-Cal and Medicare.
Thanks, Craig. So Medi-Cal is a very important program for the folks that we serve. It covers about 1/3 of all Californians. And it does provide free health coverage for individuals who earn less than 138% of the federal poverty level. And you can see what that approximate amount is this year. It goes up every year. Medi-Cal thankfully covers PrEP medications and related clinical services without cost sharing, and it also doesn't require a prior authorization or step therapy for PrEP or PEP. So next slide, Echo. And then Medicare. And again, Craig explained Medicare. It's a program for older adults and people with disabilities. And the USPSTF recommendation doesn't actually apply to Medicare as per the ACA or the Affordable Care Act, but most Medicare plans do cover PrEP and related clinical services with very limited cost sharing. Next slide, please. Thank you. So for people who are either underinsured, so your costs aren't fully covered by your plan, or if you're uninsured, there is financial assistance available through drug manufacturers. Right now, that would be Gilead, and the California PrEP Assistance Program. So the programs are open to all California residents, regardless of immigration status. But the California PrEP Assistance Program does have an income limitation on it. A person can make up to 500% of the federal poverty level. And I believe Gilead has no income limit on its PrEP assistance, its patient assistance program. Is that correct?
Yeah, so for uninsured, it does have a similar income limit. So for uninsured folks, it's also 500%. But if someone is insured and they need cost sharing assistance, there's no income limit.
Thank you. So next slide, Ayako. Thank you. So we just wanted to give you a brief overview of the complaint process before we turn it over to Raina to walk through real life and problem solving. So I think Craig mentioned some of this before, but people who are enrolled in state regulated health plans can submit their complaints to DMHC. And the reason we're doing it that way is because DMHC, the Department of Managed Healthcare, does regulate most of the insurance, the state regulated plans. If DMHC finds that your health plan is under the jurisdiction of the California Department of Insurance, then they're going to forward your complaint to CDI. People enrolled in self-insured employer health plans can submit their complaints to the Federal Department of Labor. And I think Raina is going to walk us through, or at least talk about that process. And so finding out what your plan is can be a little bit complicated. You can definitely look at your evidence of coverage, but it can be hard to find that. I know some of us have looked for our own evidence of coverage and had some trouble finding them. So you can also call your plan directly. And if you're an employer-based coverage, then you can contact your employee benefits administrator in the HR department. And I think we end there and turn it over to Raina. Are we going to pause for questions right now or go directly to Raina?
Hey, Akko, I wonder if, since we have Jessica and Amanda on, and I know Amanda has to jump off soon, while Raina's pulling up their screen, I wonder if we could just see if Amanda and Jessica, if there's any other points you want to add or anything we may have gotten incorrectly, about anything we may have gotten wrong about any of this that you want to clarify?
No, I don't think anything. You got it all right, and we appreciate your continued outreach to the department and working with us to develop a lot of the materials that you'll be handing out today. So yeah, everything looks good. I'd say, and I think we've reiterated, and I think you've reiterated here too, it's always important to know who your coverage is regulated by. Certainly we can do the handoff to CDI or potentially Department of Labor, but that will take a little bit of extra time. So we certainly encourage folks to know coming in who their insurance is regulated by. but everything else looked really good. And we encourage, please, we have a right up here as I see it. I think this is maybe what Raina's going to get into, so I don't want to take too much more time, but we do have a Department of Managed Healthcare. We have a help center that's fully staffed. We have a contact center, and you can submit complaints over the phone or online. And that's what we are standing by. I'm ready to assist. And most of our complaints are resolved quickly between our staff and the insurance and the health plan staff.
Great, thank you.
Hi, I'm Jessica Ryan. I'm she, her from the California Department of Insurance. And I just wanted to say that Commissioner Lara has been working very hard on increasing access to PrEP and making sure that the health insurers that we regulate are not imposing cost sharing for PrEP or related clinical services. And we look forward to continuing to work on this issue in the years to come. Thank you.
You know, and thank you, Jessica, for reminding us about Commissioner Lara's work on this, because he has been really active at the federal level as well and pushing this issue forward. And again, we really appreciate his leadership and participation.
Without further ado, Raina, thanks so much for taking this piece, walking through the complaint process and giving us a real live view of what it means to engage with these systems. So please take it away.
Awesome. Thank you so much again. My name is Raina, and I do a lot of the benefit navigation with our clients at the SFH Foundation. And so, you know, whatever I go over is just going to be kind of around the instructions we've been provided, as well as kind of how we submit our complaints. And if anybody else has any suggestions or feedback, feel free to add it in the chat. So essentially, to be able to file a complaint, it's pretty easy to access the page online. You just go to dmhc.ca.gov, and right away, the first thing that you see is file a complaint right there, nice and big and green on the left, and it kind of is kind of all over the place again on the right. But what we essentially do is we scroll down to the bottom, and you can see that there are different ways to submit complaints, right? You can submit it online, submit it via mail, and submit it via fax. And as it says on the bottom, the DMHC does encourage folks to file a complaint online. And we can say from experience, it makes the process a lot quicker, a lot smoother, and it avoids any delays that you would inevitably experience either through mail or fax. There have been also some instances where some folks will submit things via email. Again, the online option is the quickest and best way. As of right now, it's only in English and Spanish. So really take that into account when working with your clients. If they only speak Spanish or English or don't speak either of the two languages, kind of making sure that there's a navigator involved or someone at the facility that can provide the support through the process. And so here, just kind of this is what the online complaint form looks like. And again, it's called either an IMR, the independent medical review, or the complaint form. It will ask for very basic information on the patient, their contact information, their health plan information, which is again, all information that you should be able to collect from the client. Something really, really important to remember is that if a client is being assisted by a navigator, a social worker, a caseworker, you must select that there is somebody that will be assisting you with your complaint. If you do not select that, there will not be an authorized person who can assist. If you call, you will not be provided any information. And so it's in the best interest of the client to just make sure you select yes and you complete the authorized assistant form, which again, if you go back to the complaint area, on the first page, it's right at the bottom here, both in English and Spanish. And the complaint form is right here as well. This is what it looks like popped up. Essentially, on the actual complaint form, you'll fill in all of the information. Again, it does feel like double work, but again, just please make sure you do that so that again, it matches when you call and you have to verify your information as the authorized representative, because DMHC rep may ask for your address, your phone number, et cetera, to confirm that you are the person who is listed as a rep. And then essentially again,
I'm
Yes.
sorry, this is Anne. I realized there's something we forgot to cover, and I'm wondering if you can speak to it. Typically, when you file this type of complaint, you need to have filed an appeal with your plan first.
Yeah.
Can you explain how that works? And I'm
Yeah.
sorry,
Yes. And that was on my bullets to cover as well. Where is it? It does ask. Let's scroll down. I can see it right here. Have you filed a complaint or grievance with your health plan? So for the vast majority of complaints that are submitted, it is required that you do submit a complaint with your health plan first. That is stated clearly throughout the first page where you can find the complaint form. For this situation, for pre-exposure prophylaxis, that is not the case. You do not have to submit a complaint to your insurance plan first, because that could easily take anywhere between 30 to 45 days to be resolved. And again, this page has not been adjusted and likely won't be, because again, this is an exception to the rule. So what we do for folks is we just we put no, because we haven't, and ideally, or from our understanding and experience, the staff over at DMHC who are processing these requests and complaints do they do know that this is not required for these types of complaints to go through the insurance first. But sometimes it will get flagged and folks may be instructed to submit a complaint. In any case, one of the things that we do at our facility is we actually call within 2 to 3 days of submission. So before hearing back from DMHC, just to confirm that this was not flagged for any reason and that it's not just going to be bounced back to us in 7 days with instructions on filing a complaint to our the insurance plan first. But again, we haven't seen this as of late. So and again, for 4 or 5 months ago, things were very different. There was training going on kind of across the board, and it was taking some time to kind of for everybody to be on the same page. But as of right now, we haven't run into this flagging issue. And if you have filed a complaint, then you would just put yes. But again, that is not a requirement, although it is stated on the complaint page. Is that good? I think that was clear. And then here again, you just answer any of these questions as needed, whatever medical condition or whatever diagnosis the provider selects, ICD-10 codes, etc. And here at the bottom is where, again, you would just describe kind of the issue that's going on. And just for an example, I have here, my insurance carrier is requiring a prior auth to be submitted. This is in violation of SB 159, which prohibits PAs for either of these medications. Again, from our experience, especially as of late, DMHC reps and lawyers are very well versed on this at this point, but it's still helpful to just kind of give a brief overview. We're still submitting full letters, including all plan letters and these fact sheets. Again, any documentation that can be submitted is helpful, and that can be attached here at the very bottom. You just attach the documents and we submit. Again, the fact sheet that had the most updated one, as well as chart notes from the PrEP enrollment visit from the provider, stating that it's clinically necessary for the person to be on PrEP, selecting their medication, and submitting the HIV negative test, as well as the kidney lab. And then you just go to the bottom. Again, they could collect some statistical information around language, race, and ethnicity. You sign and submit and agree to that you're the person who you're stating you are. And just kind of agree to all the statements, submit, and then you should have a case number that you could follow up with the DMHC with. And again, what we do on our end, you will hear back ideally within like 7 days. But we still follow up within 2 to 3 days just because we want to make sure that it was received. And 7 days does feel like a long time for us to hear back. Another thing is that depending on how the complaint is categorized, it may be eligible for an expedited review, which means that it should be resolved and or taken care of within 7 days as opposed to 45 days. From our experience, all of our complaints have been eligible for expedited review, given the potential consequence of somebody not being on pre-exposure prophylaxis and being at risk for HIV. There have been pushback sometimes, and my team will just say, could we speak to a supervisor, and then the supervisor will typically clear it up. but we have not had anybody who's had to wait 45 days to hear back. And again, like really from a race equity lens, we really prioritize like our Black, Latinx clients, trans clients, folks who already have a low uptake in PrEP and who are most impacted by HIV. Again, we have 3,500 people in our program, and we can't necessarily submit a complaint for everyone who has an issue. And so when figuring out how to prioritize, it's typically folks who again have the least uptake, because we're trying to address that. So, and if the plan is not under the jurisdiction of Department of Managed Healthcare, they very neatly write us a letter with very clearly like where the complaint should be sent, whether it's through Department of Insurance or the Department of Labor. And I don't have the Department of Labor site pulled up, but this is the one for the Department of Insurance. And again, the process is actually almost identical. And there's more PPO plans that are under the DOI. Again, you just click file complaint, and it's again, filing it online is the quickest way to get it submitted. We'd have submitted a few that way as well. So yeah, if anyone has any questions or any feedback, more than welcome.
Raina, we have some quick questions for you.
Yeah.
The first one is, do you typically file, or members of your team file as the navigator, the person working on with the patient or the client, or do you encourage the patients to file it themselves?
I'm sorry, wait, it kind of, it cut out for me. Can you say that again? Or is it in the chat?
Sure.
There's a lot of questions.
Do you, I'll go ahead and restate it so that everyone can hear it as well. So do you file the complaint to DMHC yourself as a worker serving a patient, or do you encourage patients to do it themselves?
For the most part, we have submitted it all for clients. Again, getting on PrEP already is more complicated than it should be. We do fortunately have that capacity, and so we try to submit it for everyone. There have been maybe one or two folks who are like, no, I can do this on my own, and that's fine. But for the most part, we do it on our end. We have had experiences, not with this in particular, but other different programs that we tell folks about, and they're like, I'll get to it, and they don't. So we often do it for folks, like 99%.
Right. That's super helpful. And in terms of sort of the acknowledgement of the claims that you submit, does that come to you in the form of a email, or how is it that you know what's happened with the particular claim?
They send us a receipt via email of confirmation of the letter, of the complaint via a letter, and they will send it to the client. They will email the client first and then CC whoever is the authorized representative.
Thank you so much. I know I've been dropping it in chat, but I just want to really open up the floor to any questions that folks have, even if you haven't put it in chat or not. We'd love to hear from you. One of the things that, when we're all sort of together in this space, we'd like to do is ask about what problems you all might have encountered so far. Are you seeing anything related to cost sharing that's been problematic? Is there anything related to submitting complaints in terms of your experiences that you'd like to share with us? So I just want to open up the floor to getting that input from all of you that are participating today. And again, we'll take that in the form of a chat, or if you're interested in raising your hand, we'd love to call on you.
Nayako, could I just highlight one issue area that I'd love to hear if people have any experience with is, I noted when Craig was talking about the self-insured employer-based plans, that if a PA was used, it was supposed to not stop PrEP initiation on that day. And I'm just curious if anyone's seen any problems or had any experience with that part of the process as well.
While folks are responding to that, we do have a question about pharmacies that are asking for PA. So I'm curious if any of you've seen that, any of our panelists have seen that or experienced that, and really what is the response to that?
Yeah, so happy to address this one, and Raina and please chime in as well. So Medi-Cal eliminated prior authorization requirements, sometimes called treatment authorization requests, or TARs. I believe, Anne, in 2014. We did see a lot of issues still with pharmacies kind of telling patients that PrEP required prior authorization. And so DHCS actually put out a notice in 2017 that I can drop in the chat, just kind of talking about these erroneous treatment denials that were taking place around PrEP. And so this came up kind of on one of the PrEP listservs last week. And I think one of the really important pieces of advice was HIV medications in California are kind of what's called carved out of Medi-Cal managed care. And so sometimes when a patient goes into the pharmacy will be trying to bill the medication to the managed care plan instead of directly to Medi-Cal through the state carve out. And so I think just making sure that pharmacies have accurate information about how PrEP and HIV medications need to be billed. I think the notice that DHCS put out in 2017 is something that you can just print out and share directly with the pharmacy or health plan. So again, I'll throw that in the chat, and then Raina and Anne or anyone else, if you have anything else you want to add to that, feel free to chime in.
Yeah, unfortunately, we are still seeing those unfortunate TARs that are, as you stated, incorrect. Thanks for the kind of like your suggestion on what folks should do. Other things that we do, again, because it can take some time to educate and provide technical assistance to these pharmacies, is identifying local HIV specialty pharmacies in the area that kind of across the board know how to bill these things correctly. Again, if often clients would choose a pharmacy where it's like they may be one of the first PrEP clients on Medi-Cal, and they will run into this issue. We could experience a lot of resistance and delays. So often we just pull that prescription out. And with so many specialty pharmacies that can mail essentially throughout the state, that's one of the things that we've utilized.
And the other thing I would say is that assuming that the change in the pharmacy benefit in Medi-Cal moves to Medi-Cal RX, or all of the benefit moves into Medi-Cal RX as opposed to the managed care companies in January 2022, which is when it's expected, I assume we should stop seeing that. Would you agree, Craig?
Yeah, sorry, I was reading some of the comments in chat, so I missed your entire comment.
Just that when we move to Medi-Cal RX, so the whole pharmacy benefit moves into Medi-Cal as opposed to managed care plans, we should see that erroneous practice stop.
Yeah, absolutely.
In the meanwhile, Craig and I were reading the same note. Really great to lift up, folks that are really intervening and asking pharmacists to call the insurance company to make sure that the problem gets resolved there. So really great information, you all. I just want to open up again. Anybody participating today has a story to share or some feedback or some information from the front lines that you'd like to lift up, please feel free to raise your hand. Happy to bring you up to the conversation. I see Nestor. Nestor, would you like to share with us?
Yes, can you all hear me? Okay. So hello everybody, my name is Nestor and I am a PrEP navigator in Southern California, San Diego, California. But one of the things that I ran into, I want to say it was about a month and a half ago, one of our patients on PrEP received notice from their insurance plan that they were currently already on Truvada. That was the medication that they were utilizing at the moment, but they were notified by their pharmacist that it was no longer covered. And so the pharmacist actually took the time to call and talk to us. And we figured out that the pharmacies noticed that the formulary had been updated and that Truvada had been removed for prevention purposes on that particular plan. And so that was really odd because there wasn't like an option for like either generic Truvada or Truvada. It was just that Truvada had been removed. And I don't know if maybe there was an error on the insurance parts particularly, but it just made it so that we had to switch the patient into the Descovy. Luckily for us, the patient was eligible to choose Descovy as a second option. But it was one thing that happened. So I'm just curious if anybody has experienced this similarly. I know that we've been having some of these little hiccups when the insurances may update the classifications for the medications and maybe prioritize generic Truvada versus brand Truvada, for approval and things like that. And those kind of things sometimes we have to be on top of, because if a patient was receiving one class of Truvada, they may no longer be able to receive that from their insurance provider. But I hadn't seen somebody just get told that Truvada as a whole was not approved for prevention purposes. So I'm just curious to hear if anybody has that same experience. But yeah, that was my sharing.
Thank you for that. Raina, it looks like you have some feedback on that for us.
Oh no, I have not seen that, but I'm just really surprised that an insurance company would pay thousands of dollars as opposed to what generic Truvada is right now, the cost of it, which is very low. But it looks like from the chat, it looks like maybe
I'm
somebody
seeing
else
there's a few folks.
that.
Yeah, Jasmine, you like, okay.
Yeah,
Okay.
we've usually seen just Truvada, brand name Truvada taken out, and then they have generic.
Right.
But yeah, I haven't seen that. That's interesting though.
Yeah, so it looks like some PPO plans have that issue.
Yeah, I mean, I can just add in terms of, we talked about state regulated versus the federally regulated plans, and an issue that we were seeing early on and an issue that we worked on with Jessica was plans removing Descovy from their formulary. So it was slightly different. And DMHC came out with guidance earlier this year, basically saying that plans, removing medications from your formulary is a form of prior authorization or step therapy. And so they had to keep those medications on their formulary. But the only caveat being is that they would be required to keep medications without a generic equivalent on the formulary. So state regulated plans are required to cover Descovy. But Jessica, correct me if I'm wrong, I think my understanding of that guidance would be that the state regulated plans could remove brand name Truvada from their formulary if they covered the generic version.
That is correct. So as long as, because generic and brand name are therapeutic equivalents, the exact same drug, they can prefer generic Truvada, but they always have to accept any request from you that generic Truvada is someone has a contraindication or some other reason why they can't take it, then they should quickly approve brand name Truvada for those people. And I would be very concerned about removing generic Truvada from the formulary, because people who are at risk from vaginal sex cannot, it's not FDA approved for that. And so that would be an extremely concerning development, but I have not seen that. Most of it's been around trying to, funnel people into the generic option.
So it's possible, if you do see that again for client, to determine if their plan is state or federally regulated, and submit a complaint if possible. It is really unusual that they would choose to do that, but they shouldn't be.
Same thing that I thought when the pharmacist was on the phone with me. But like you said, luckily for us, this patient was eligible to choose Descovy. Had they been a patient, at risk from vaginal acquisition, that's where we would have had a lot more trouble,
Thank you so much. Are there any other folks with us today that have a story to share or an experience or a question? We welcome you to speak up. Just go ahead and raise your hand.
One thing I did want to add, Nestor, to Nestor's situation is, in that situation, I'm not super sure, but do you know if the person would have been eligible for Gilead's patient assistance program? Did you all try that at all? Just for
I think because they were already insured and they had already
Yeah.
insured benefits, they would have been able to
Wow.
qualify.
Descovy.
Yeah.
That's messy.
And I've had conversations with Gilead because we've had sometimes patients who have insurance of some kind, but once Gilead, the response that I get from their program is that once on their system they can see that a patient has some sort of insurance, then that automatically kind of disqualifies that patient from being enrolled in the program.
Yeah.
The only thing that we can is we can ask for a benefits investigation, an in-depth benefits investigation, and then they'll look closely to see if they have drug coverage associated with PrEP. But in this case, luckily they were able to go for this COVID.
Yeah, got it.
Well, we have somebody with firsthand experience submitting a complaint. Not sure if he's teed up to share his story, but if folks don't have any more questions, I think it's great to hear what that firsthand experience is like, and perhaps in some ways encourage folks. You know, Craig, if you're open to sharing, I'd love to sort of get your take on why it is important to use this complaint process. And really why groups like RANA's are, you know, intent on doing it, particularly for, you know, the more vulnerable folks. That'd be great to hear from you.
Yeah, happy just to share kind of patient perspective on submitting a complaint, albeit a patient that has a lot more, you know, healthcare knowledge than, you know, most of the patients that we work with. But the last time I went in for my PrEP labs for kind of regular HIV and STI testing, I was charged a copay and was concerning to me, obviously, given kind of all of the advocacy that we've been doing around cost sharing for PrEP. So I'm in Southern California. I have a Kaiser health plan through my employer. So I did not pay the copay, and then I proceeded to submit a complaint to the Department of Managed Healthcare. Like Raina said, I did receive notice pretty quickly, definitely within 7 days that they had received the complaint. I want to say probably a week or two later, I received notice from DMHC that they had actually closed the complaint because they said I needed to submit a complaint to my health plan first. And as Raina discussed, that is not required. We worked with DMHC and CDI so that patients can submit complaints directly to them without having to go to the health plan first. And so I talked to DMHC and kind of raised this as an ongoing issue. And they said that they would retrain their staff to make sure that this doesn't happen moving forward so that patients can submit complaints directly to them. After that happened, they did reach out to Kaiser to address the issue. And just last week, I received a letter from Kaiser informing me that the cost sharing would be waived because PrEP is a preventive service. And so I would not be charged those copays. One thing I learned from that process is kind of the importance of billing codes that are used. And, you know, the providers and labs, the health plan needs to know that this is a preventive service in order to cover it without cost sharing. And so there has been some education happening at the health plan and provider level to ensure that kind of the proper billing codes are used so that when patients do go in for their labs or to pick up their medication, that they're covered without cost sharing. So just thinking about issues that might come up is sometimes if a service is not coded correctly, you might get charged cost sharing. And so, you know, that's an issue that you can raise with your provider or your health plan directly, but there's also kind of advocacy happening to make sure that health plans and providers are aware of the importance of billing these services correctly.
Thank you so much. I just appreciate you sharing your personal experience. I think, you know, like you said, you have so much knowledge and wherewithal to be able to do that. And as mentioned in our chat, you know, not everybody has it. So for all of you doing that really important work on the ground, you know, helping people to navigate this process, I think it's just incredibly helpful and important work. Was there anything else from our panelists that you all want to share today?
Yeah, I'd just like to lift up this this question again, because it really struck me when Craig was covering the self-insured plans. And that's where we would expect, of course, to see more PAs and perhaps even step therapy, because they're not regulated to prohibit those. And I was looking at the requirement that people be able to start PrEP the same day. And I'm just curious if people are seeing that happen, or if they're seeing what is usually a pretty complex and sometimes lengthy PA process going on in those plans, if you've worked with any self-insured plans that you're aware of and that had a PA process.
Yeah, I'll touch on that real quick, because I know you initially had mentioned me when asking that question, but it was getting lost through everything else. Yeah, I'm not logistically, I don't know how that would be possible. We have been able to have folks start on PrEP, but that's either because, you know, we have samples from the pharmaceutical company, or we have been able to purchase some of the generic, but have not been able to get any paid claims for people who are self-insured in order to start PrEP same day. It's kind of one of those things where in theory it's, you know, but we have not seen it.
Thank you so much. So I think, Craig, this is an area where we probably need to do some implementation advocacy. Yeah, thank you, Raina. And if any others do experience that, if they could let us know if possible, that would be super helpful as we start speaking with people about this.
Great. So in order to facilitate some of that too, I went ahead and dropped my email in the chat so I can help funnel these comments, questions, any experiences that you have. If you send them my way, I'll be sure to share them with this panel. I think that the information flow is just so critical to making sure that implementation goes smoothly. And obviously we're hearing a lot about how it, you know, it can be a bumpy ride, but we're all in the car together. So that's the good news. If there are no other questions, I'm going to go ahead and just move us to wrapping up here. The first thing I want to say is, you know, we recognize the Gabrielino and Tongva ancestral relationship to the lands upon which we at UCLA learn, teach, and engage on. I also like to recognize those people whose unpaid and underpaid labor remains unnoticed and unappreciated. And I just want to thank all the people that make it possible for us to do the work that we do. I want to thank our speakers, Raina, Anne, and Craig, for bringing to us this important information. I've popped in the chat multiple times, the fact sheet, which is a real quickie version of the policy brief, which is all the information that was shared with you today. What we look forward to is sharing the slides as well as the recording with everyone. Again, at our website, dropped in the chat there, www.chprc.org. And if you all are hanging in with us this long, which so many of you are, I'd love for you to go ahead and complete our evaluation. We're going to pop it up as a poll here. It's just great feedback for us to get. This is the type of programming that's really critical. I know there's a lot that you all could be doing right now, including delivering services, but the fact that you're here to get this information means something. So, you know, rather than doing our research for research's sake, our policy work for policy work's sake, we'd love it to be something that's responsive to your needs and informing your work, and vice versa. So please take seriously the offer to just email me directly so that I can connect with our panelists, these important stories and experiences that you've seen your clients and your patients face, and how we might be able to look at you know, critical responses to those experiences. So thank you so much on behalf of the California HIV/AIDS Policy Research Centers. We appreciate your time and your commitment, and we look forward to seeing you soon.